Good morning, everybody, to our weekly resident lecture. The topic today is pancreatic cystic neoplasm. It's an important topic, and Samuela, who is our fourth year resident, will give us a very comprehensive overview about this important pancreatic disease. Okay, please.
Thank you very much for the introduction. Good morning and welcome, everyone. As mentioned before, today I'm going to talk about pancreatic cystic neoplasms. I will start with a few epidemiological data, followed by classification and clinical presentation. I will continue with diagnostic tools and workup and talk about treatment and follow-up of pancreatic cystic neoplasms. Last but not least, I will finish my presentation with a short summary. The increased use of high-quality cross-sectional imaging and the trend for healthy individuals to undergo preventive health checkups have increased the detection of pancreatic cystic neoplasms. The prevalence of pancreatic cystic neoplasms varies markedly with the type of imaging used and among studies. Whereas abdominal ultrasonography detected a pancreatic cystic neoplasm in 0.2%, the CT revealed a pancreatic cystic neoplasm in 2.6%, and the MRI and MRCP in 2.4 to 49%. In autopsy study, a pancreatic cystic neoplasm was detected in up to 50% of the patients. A study published in 2010 in the American Journal of Gastroenterology retrospectively investigated the prevalence of incidental pancreatic cyst in a population with 616 patients who underwent the MRI for no pancreas-related symptoms. As shown on the image, they found an increasing incidence with higher age. The total prevalence in this study was 13.5%. As the overall incidence of pancreas cancer-related mortality is fairly stable, the increase in detection of pancreatic cystic neoplasm is due to the increased use of abdominal imaging and the higher quality of that imaging. So more imaging is producing a higher number of asymptomatic cysts. As the role of cystic tumors in carcinogenesis of the pancreas is not precisely known yet, the main difficulty is to distinguish between potentially malignant tumors and harmless cysts. So which pancreatic cystic neoplasm should be surveilled closely and which one should be resected? Dear residents, what type of pancreatic cystic neoplasms do you know? Yes?
There is the serous cyst adenoma, the mucinous cystic neoplasm, and the IPMN, for example.
Really good. Thank you. Today I will only talk about these four pancreatic cystic neoplasms, which account for about 90% of all pancreatic cystic neoplasms. Serous cystic neoplasms account for about 30 to 40, mucinous cystic neoplasms for about 10 to 45%, solid pseudopapillary neoplasms for about 5%, and intraductal papillary mucinous neoplasms for about 20 to 30% of the pancreatic cystic neoplasms. As I mentioned before, most pancreatic cysts are asymptomatic and discovered incidentally on diagnostic imaging. The most common symptoms in a surgical case series with 131 patients with symptomatic pancreatic cysts were pain, which was seen in about 70% of the patients, weight loss and acute pancreatitis in about 40% of the patients, jaundice and back pain in about 20%, and a palpable mass and postprandial fullness in about 5% of the patient. So which diagnostic tool should be used in unclear pancreatic cystic lesions? The MRI and MRCP have the advantages of non-invasiveness, better detection of communication between the main pancreatic duct and the cyst, and a better depiction of the internal morphology of the cyst. Disadvantages are a lower spatial resolution as well as insensitivity for identifying calcifications. In a few minutes, I will explain why these characteristics are so important in differentiation of the pancreatic cystic neoplasms. Now, different studies showed an accuracy in diagnosing cyst type between 40 and 50%. MRI and MRCP have a high sensitivity for diagnosing IPMN, which was found to be up to 96%. The accuracy in determining benign from malignant pancreatic cyst was found to be between 55 and 76%. Now, comparing the CT to the MRI and MRCP, a better spatial resolution was found, as well as a higher sensitivity for identifying calcifications. Disadvantages are radiation, as well as a lower detection of communication between the main pancreatic duct and the cyst. The CT also has a lower sensitivity for diagnosing IPMN compared to MRI and MRCP. The accuracy in determination from benign from malignant pancreatic cyst was found to be between 71 and 80%. Looking at the endoscopic ultrasonography, a greater accuracy for identifying a mural node was found. The main advantage of the endoscopic ultrasonography is the possibility to perform a fine needle aspiration. As an endoscopic ultrasonography is invasive, it is not recommended as a first-line examination. The accuracy in determining benign from malignant pancreatic cyst was found to be between 65 and 96%. Now, which role does the PET-CT scan play in unclear pancreatic cystic lesion? A systematic review evaluated 4 PET studies for identifying benign from malignant pancreatic cysts, and they found PET alone to be inferior to CT and combined PET-CT to be superior to CT alone. A recent prospective study of FDG PET-CT, multi-detector CT, and MRI combined with MRCP found a diagnostic accuracy in determining benign from malignant pancreatic cyst of 94% for PET-CT, 77% for multi-detector CT, and 87% for MRI. Despite these initial promising results, there is insufficient evidence to support the standard use of PET-CT currently. Now, according to the American College of Gastroenterology guidelines, the MRI and MRCP are the imaging modalities of first choice, with CT and endoscopic ultrasonography being excellent alternatives in patients who are unable to undergo an MRI. Multicenter prospective observational study found an increased sensitivity for identifying IPMNs and MCNs, as well as cysts with high-grade dysplasia and invasive cancer when MRI was combined with endoscopic ultrasonography. Larger retrospective studies showed a similar finding when CT or MRI were combined with endoscopic ultrasonography. So indeterminate cysts may benefit from a second imaging modality, as well as from endoscopic ultrasonography with fine needle aspiration and cyst fluid analysis and cytology. The most commonly used cyst fluid marker is CEA, which was found to have a pooled specificity of 93% and sensitivity of 63% in differentiation of IPMNs and MCNs from other cyst types. The cyst fluid amylase may be helpful if the presence of a pseudocyst wants to be excluded, with excluding the presence of a pseudocyst in about 98% of the cases with a very low amylase level. The cyst fluid CEA is not helpful in identifying high-grade dysplasia or invasive cancer. A systematic review found that cytology has an excellent pooled specificity for pancreatic cancer, but suffers from a low sensitivity of 65%. Recent study found that integrating molecular markers with cyst clinical features showed an increased sensitivity and specificity for identifying IPMNs and MCNs, but unfortunately they are very costly and did not help in determining the pancreatic cancer risk. So now I would like to focus on the clinical imaging and cyst fluid analysis characteristics of the 4 pancreatic cystic neoplasms mentioned before. Serocystic neoplasms are mostly found in patients between 50 and 70 years of age, and there's a female predominance. They can be located anywhere in the pancreas, and in 50% of the cases, they are found in the body and tail. There is no communication between the main pancreatic duct and the cyst. On imaging, they appear as microcystic lesions with a characteristic honeycomb pattern and a stellate scar. The cyst fluid analysis shows a low viscosity as well as a low CEA and amylase level. The malignancy rate was found to be very low with under 1%. So here you can see the typical microcystic lesion with the honeycomb pattern and the stellate scar. Mucinous cystic neoplasm are mostly seen in patients between 40 and 60 years of age and in over 90% of the cases in women. There is also no communication between the main pancreatic duct and the cyst, and they are mostly located in the body and the tail of the pancreas. On imaging, they appear as macrocystic lesions with peripheral calcifications, and macroscopically, they are mostly large cysts with a thick wall. The cyst fluid analysis shows a high viscosity with an elevated CEA and a low amylase. The malignancy rate is quite high, between 10 and 17%. Here you can see the large macrocystic cysts with peripheral calcifications and the thick wall. Now, solid pseudopapillary neoplasms occurs mostly only in young women, and they can be located anywhere in the pancreas. On imaging, they appear as macrocystic lesions with areas of hemorrhage, which are macroscopically seen as irregular cystic cavities with hemorrhage. The cyst fluid analysis shows bloody necrotic debris, and the malignancy rate is as well quite high, between 8 and 20%. So this is an example of a solid pseudopapillary neoplasm. It's a large cyst with areas of hemorrhage. Now, looking at the antroductal papillary mucinous neoplasm, the distinction between main duct and branch duct IPMNs is very important for progression and prognosis. As shown, the main duct IPMN is located in the main duct and can be divided into segmental and penductal IPMN. Branch duct IPMN are located in the branch ducts, and mixed type IPMNs affect both the main duct and the branch ducts. What are the main differences between the main duct and the branch duct IPMNs? As already mentioned, the main duct IPMN is located in the main duct and is characterized by segmental or diffuse dilatation of the main duct. Almost 70% occur in the pancreatic head, and the pancreatic tissue often shows signs of a chronic pancreatitis. 60% of the main duct IPMNs are associated with high-grade dysplasia and 45% with invasive carcinoma. Branch duct IPMN are located in the secondary branches and present as mucus-filled cysts. They are mostly located in the head or the uncinate process. 25% are associated with high-grade dysplasia and 20% with invasive carcinoma. So IPMNs are mostly seen in patients between 60 and 70 years of age, and in contrast to the other three pancreatic cystic neoplasms, there is no female predominance. The cyst fluid analysis shows a high viscosity as well as a high CEA and a high amylase rate. As you may see, the malignancy rate of branch duct IPMNs is significantly lower compared to the malignancy rate of the main duct IPMNs. The malignancy rate of the mixed type IPMNs is comparable to the malignancy rate of the main duct IPMNs. That's why mixed type IPMNs are treated as main duct IPMNs. So here a main duct IPMN is represented with dilatation of the main duct, the typical mucinous filling, and during ERCP, the characteristic fish mouth sign can be seen, which is characterized by mucus coming out of the papilla artery. A branch duct IPMN with dilatation of one of the branch ducts and the typical mucinous filled cyst in the resected pancreatic tissue. Last but not least, a mixed type IPMN with dilatations of the branch ducts as well as segmental dilatation of the main duct, and the fish mouth sign can also be seen in mixed type IPMNs. Now, how should you proceed with a diagnostic workup in incidental pancreatic cysts? On this slide, the World Gastroenterology Organization workup guidelines are represented, which were published in March 2019. I don't want to go into details, but the only thing I want to show is that there are different criteria which help you to decide whether to observe or resect a pancreatic cystic neoplasm. The three most important things to remember are that there exists high-risk stigmata for malignancy, that you should perform an endoscopic ultrasonography fine needle aspiration to distinguish serous from mucinous cysts, and that worrisome features may help in stratifying the risk for malignancy. Now, how closely should pancreatic cystic neoplasms with indication for observation be surveilled? As shown, the surveillance interval depends on the size of the largest cyst. If the size of the cyst doesn't change on the first surveillance images, the interval of the surveillance can be extended. A surgery should be considered in cysts between 2 and 3 centimeters of size in patients who are fit, and as well as in cysts with a diameter over 3 centimeters. Now I would like to summarize the treatment algorithm of the 4 pancreatic cystic neoplasms presented before. Serous cystic neoplasms have a very low malignancy rate, and that's why they should be surveilled. At least, if they're symptomatic, consider surgery. Mucinous cystic neoplasms have a high malignancy rate, and that's why they should be resected. Solid pseudopapillary neoplasms also have a quite high malignancy rate, and that's why they should also be resected. Now, looking at the IPMNs, as already mentioned, the distinction between main duct and branch duct IPMNs is really important for progression and prognosis. That's why main duct and mixed type IPMNs should be resected due to the high malignancy rate. Branch duct IPMNs with high-risk stigmata should be resected as well. And branch duct IPMNs with no high-risk stigmata and no worrisome features can be surveilled. Now, branch duct IPMNs with worrisome features, surgeries should be recommended to fit patients who prefer surgery. And if a surgery is not preferred, then regular endoscopic ultrasonography should be performed until high-risk stigmata are presented. What kind of surgery is now recommended in pancreatic cystic neoplasms? If the lesions is located in the pancreatic head, a Whipple pancreatic duodenectomy is recommended. If the reason is located in the pancreatic tail, a distal pancreatectomy with splenectomy should be performed. Now, in IPMNs, an intraoperative frozen section of resection margin is recommended to ensure a disease-free resection margin. In case of high-grade dysplasia or invasive carcinoma, an extended resection up to total pancreatectomy and lymphadenectomy should be performed. Now remember that these surgeries have a high morbidity as well as quite a high mortality, and that's why they should only be performed in fit patients and in specialized centers. Now, how closely or how should patients with resection of pancreatic cystic neoplasms be followed up? If the definitive pathology shows a serous cystic neoplasm, no follow-up is recommended. If the definitive pathology shows a mucinous cystic neoplasm with low-grade or high-grade dysplasia, also no follow-up is recommended. In case of mucinous cystic neoplasm with invasive cancer, the patient should be followed up with the pancreatic cancer guidelines for at least 5 years. If the definitive pathology shows an IPMN with invasive carcinoma, the patient also should be followed up with the pancreatic cancer guidelines for at least 5 years. In case of an IPMN with high-grade dysplasia, the patient should be followed up every 6 months due to the high recurrence risk. And in IPMNs with a low-grade dysplasia, the surveillance interval depends on if there is still a cyst in the remnant pancreas or not. If there is still a cyst in the remnant pancreas, then the surveillance interval depends on the size of the cyst, as already mentioned. If there is no cyst, then the patient can be surveilled every 24 months. Solid pseudopapillary neoplasms have a recurrence rate of 4% with a median recurrence in 50 months, and that's why they should be surveilled yearly for at least 5 years. So last but not least, the summary. Remember that the rising incidence of pancreatic cystic neoplasm is due to the better diagnostic tools, that many cysts are incidental findings and benign or low-grade neoplasms, that mucinous cystic neoplasms, solid pseudopapillary neoplasms, and main duct and mixed type IPMNs, as well as certain branch duct IPMNs, have malignant potential and should be surgically removed. That the main duct and branch duct IPMNs is an anatomical and prognostic distinction. That high-risk stigmata and worrisome features stratify the risk of malignancy in branch duct IPMNs, and the patients with unclear pancreatic cystic neoplasms or with indications for surgery should be referred to a specialized center. Thank you very much for your attention, and I'd be glad to take your questions now.
Very, very good presentation. Excellent. Top 100%. Very good. I mean, everything was perfect. And when I have to write in this survey how to do it better, I'm not sure what to put. Something is missing. This is, in addition, a very difficult topic. I think you cover well the diagnosis and treatment and the difficulty of few points and maybe one questions. First, what you show so is that this should be discussed in interdisciplinary conferences with gastroenterologists. The reality, in many places, the surgeon, we show all the cases. There are many cases that are not shown to us, that are decided by the colleague of gastroenterology. I don't want to say many bad things, but that's the reality. And in addition, they are doing the guidelines. If we look at the ratio, not all, but many of these consensus or whatever, is a lot of gastroenterologists. And we should not forget that all these guidelines are level 5 evidence. We don't have randomized trial, we don't have everything. So we have to be careful, because you sit here, you see some worrisome features, etc., and then somebody come and just comment on the guidelines. So I just say the guidelines are an important tool, but this is not the Bible or whatever text we want to read that should say the truth. So that, I think we have to be careful and critical. One question, you report the incidence of malignancy. Is that incidence? Is that prevalence? Is lifelong, or is that the time of the diagnosis?
No, this is lifelong.
So it's lifelong. So
Yes.
that means, the mucinous tumor at this. But I was a little bit impressed by the high rate of side branch IPMN, where you show, if you go in many, they will quote that the risk is 0. And here I can read about 20% or 12 to 20%, which is basically the same here, right? It's pretty high. It's very high, the higher that was ever heard about this. Or in guidelines, they are saying, and one of the issue, which was shown in this large series, that many side branch end up, in fact, to be mixed. It's not easy, and when you do the histology, you find, if I'm correct, in 25% or 30% of the case, some high-grade dysplasia in the main duct. So, and this is relatively new. All this entity did not exist a couple of decades ago. So, also in the guidelines, you say, well, if patient like surgery or something, this is also for me very strange to read in the guidelines, where you go and say, well, we don't know. What do you want? Do you want to live with this? And maybe you have a cancer, or we operate. Also, something that disturbed me a little bit is age of patients. Of course, we have to adjust for age. We will not react in a 30 or 50, but when in guidelines all the time you have age, I interpret that as we don't know exactly what is going on in this. So again, I think this case should be all or most of them discussed at interdisciplinary conference, which is not the case. So our surgeon very often, and that's the reality, we just operate what the gastroenterologist thinks should be operated. So we don't have the main pictures on that. So I think we have to be very careful, and we regularly have patients with cancer. That means that they were not diagnosed early on. Yet I think very simply the serous one, if we should not be operated, that's clear. And there's also abuse on this side in many countries with fee-for-service. There is no check, and these patients are just operated. That's probably not right. But on the other hand, there are patients that should be operated. They go through guidelines or ask the patient what he wants, and at the end they develop later on a cancer, and they should have been operated in this situation. Just wanted to make a comment. So again, congratulations.
I think the patient wish is sometimes important because these cysts are not always black and white. We have many gray areas, and I have several patients who, even in this, I would say, spectrum, have a strong wish to the lesion. And then this comes into the equation. I think this is important. I think this is important not only for this disease, for all disease, where it's not 100% clear that this is an indication. We had a slide, which we did not present of time reasons, on relative and absolute criteria when to resect. And this slide shows basically also, the relative indications for surgery. And I think then it's important also to listen to the patient, because if the patient even does not wish or is against surgery, if you perform high-risk surgery and it's not clear, then I think this is also important. Just want to make this point.
Thank you very much, Samuela, for this nice overview. I have two questions concerning your treatment strategy. The first one is, in a case of a main duct IPMN involving the whole duct, would you go for a total pancreatectomy up front, or would you tailor that in a specific way? And the second question is, in a left resection, do you also always have to remove the spleen, or would you that depend on the histological features as well?
Very good question. First question is, depends on the extent and the location of the IPMN. So if this is segmental, only restricted to the head, you can do a pancreatic head resection or Whipple, and then you go also for intraoperative frozen section, that we always check if we are close to the margin, for malignancy. But if the main duct is involved, I would always take it out. And we had also surprising results. I think I remember one case where we resected. We had to continue because of it was not clear what the pathologist said, and then at the end in the splenic hilum was a lymph node metastasis. So if there's any doubt, I think you should take out the entire pancreas. I think it would be not good to leave something malignant potential back. But usually sometimes they present with only IPMM in the tail or in the head, which is clear, and then you go for intraoperative frozen section. I would not go up front for every IPMN for total pancreatectomy. Not at all. Splenectomy, if you know you have to resect, I think you need to take the spleen. Because if we talk about malignant potential, many come back as intermediate or, let's say, severe dysplasia, but we also saw patients who were diagnosed with IPMN and came back with cancer. And to keep the spleen in would not be a good thing. That's my opinion.
I have a question about the branch duct IPMNs. In my opinion, or in my experience, we see quite a few of them. They show up on images and they're labeled as branch duct IPMNs. And now we understand that if there's no worrisome feature, if there's no high risk situation, they need to be followed up. But so who's ensuring the follow-up, and how many of these patients actually are at risk of terminating the follow-up? They drop out of this of their regular imaging and eventually present with invasive cancer.
Usually patients are very aware on the cyst, and it's very rarely that they drop the follow-up. So they have also always an interest. And branch duct depends on the size, and also important if this is growing. So let's say you have a follow-up over several years and it's constant in size, you're pretty sure and without worrisome features. But if this starts to grow, then things might change. And then I talk about this gray area. And sometimes also, if something is growing, patients are also unsecure and might also influence, how we decide at the end together. But it's right, we see many branch ducts which have no worrisome features which we just have to follow. And many of them are also have no change in size.
Maybe just 2 points now. I mean, what Professor Petrovsky mentioned is that if there is a malignancy, we take the spleen. If there is no malignancy, then we do usually routine with us is the Da Vinci robot, and then we keep the spleen in this situation. But if it's a tumors, standard is that if it's no tumors, then we keep the spleen. You make that also an important point. This is we may think it's benign disease, therefore it's an easier surgery. That's the opposite. They are usually soft pancreas, small bile duct, and in fact they are high risk. So I think you really emphasize that through this case should absolutely be operated in centers who have volume and experience in this disease. Okay, thank you very much. Thank you.